one and all present here. And I personally thank CAHO and QIMPRO Foundation for selecting our paper for the platform presentation. And my topic is all about the inventory management system. And the title is CARE to the Core, a lean principle incorporated farms inventory management system. And as we all know, it's a complex process. So when you think of the inventory management, it is all about like how do we effectively use the available resources with a mind of minimizing the investment and maximizing the profitability. That is what it's all about. That is what it is all about. And as we know all, it's a very complexing process. It starts from the manufacturer to the supplier, supplier to the hospital. In a hospital, we have the central store and we have multiple sub-units. So we need to maintain the inventory all over without any disturbances so that we can ensure the customer satisfaction and with the full-fledged pharmacy services. So at the same time, we could not overstock it. We could not have a lot of returns. So we need to have the balance and what to stock and what not to stock, how to maintain all the things together. So it is a difficult process. So we must have certain, how to change it, it's not working. So when the process is very complex, we must have the certain solutions and we must have certain standards tool to measure the defects and to try to overcome the defects with certain root causes to bring back the quality into our center. So we have used a Six Sigma DMAIC methodology to measure the defect in the process and to eliminate the defect to maintain the fruitful results. And I think that the definition of the problem is we are the largest trauma care center in India. We have 650 beds for the trauma care. We have 36 OTs where we used to perform nearly 70 to 90 surgeries per day. Our outpatient flow is all about 1,500 to 2,000. Think that we need to satisfy nearly 2,000 to 3,000 populations daily with the supply of our medicines and consumables. So it needs certain standard protocol or the best practices into the place to maintain all the things correctly, and we should not have all the returns, the drugs should not remain stagnant in our pharmacy. So it is always need the best practices to be placed. So it makes us to think what best we can do to maintain the good inventory practices in our center. So we have grouped the whole pattern of inventory into the 4 stages. One is procurement and distribution, and then the stock at infirmary unit, how to maintain it, and reduction of return units. Look at the differences and the phases, what we have faced in the defects in each center from 300 and 1,000, 600 plus and 200 plus. And we looked closely into the grouped parameters. When you look at the procurement defects, there is a problem in placing an order, and there should not be the proper supply against the order what we have placed. And how do we enter into the system? How do we make the GRN? And suddenly, the things will go like out of stock from the customers. Even the COVID time, you could face a lot of problems. I could, anyhow, the purchase manager here, you could feel that there are a lot of stock outs and there is a lot of deviation in the profit margins, and there are a lot of non-formulary drug has been entered into the pharmacy. So it all makes us to feel very bad to maintain the good inventory practices to satisfy our patients. And the next, into the distribution. What and all drugs it has been entered into the pharmacy, how effectively it has been transported to the different subunits, and how the subunits has placed the intent against the reorder quantity level, how they are maintaining it, and how they are properly distributing the drug to the patient based on the protocol like first in, first out policies, and how all the staffs in your unit aware of your reorder quantity level, and how we are effectively supplying the medicine to the patients without disturbances. Because when the prescription written to have the 10 drugs, we should able to provide all the 10 drugs so that the patient will be satisfied. When the one drug is not available in the pharmacy, when I report to the patient that it is not available in the pharmacy, there are high chances the whole prescription can go out. It directly disturb our inventory pattern, and it can induce the loss also. In the infirmary unit, when we are having nearly 50 to 55 plus subunits inside the hospital to keep the medicine, it's always difficult. All the healthcare workers, how effectively they are maintaining the registers, returning, doing the short expiry policy, and how they are maintaining the stock level. So there are the fluctuations in the practices inside the infirmary units also. Then written medicine, the unusual stop orders, excess intending of medicine to the pharmacy. Even they never look into the drug trolley and they will simply write the prescription to the pharmacy. So it leads to over intending. Look that for the subunit of my pharmacy, the sale will be like 5 lakh, the return will be like 60,000. There are 25 to 30% of the sold items is coming back. It again disturbing our inventory. So we must have certain standard practices to be in a place to maintain it. So this is the Kaizen method which we made by the discussion with the management and by discussing with the different heads of the units. And this is all about, we mixed ABC analysis, VED analysis, and FSN analysis. It's all related to the inventory tool. ABC is based on the cost, and VED is based on the severity and what to make and what not to make, and FSN is based on the movement. It is fast moving, slow moving, non-moving, like a drugs. So when we mix all the things, we could get to know that what drugs to be stocked more, and what drugs to be stocked minimal, and what drugs to be stocked in the lesser way. But always, we used to consider the supply lead time. When, even though you will mix all the things and when you make your own inventory practice, but think that you have to have the very clear supply lead time. When the drug is not available locally, you need to place an order from somewhere to make it available. Anyhow, you need to make the drug available in your pharmacy, irrespective of all the practices. That we need to keep it in our mind. So when we are going by practicing the standard practices into the place, when you look that, there are a lot of non-moving drugs we could find. We have taken it out, which has been placed during the crisis of COVID, which cannot be used by the orthopedic center like us, and it's occupying our total inventory values. So it can be taken out and can be returned back. And when we strengthen, then we started focusing on the infirmary units about how to place an intent. And we educated our own pharmacy unit about how to maintain the reorder quantity level. When we have different subunits in your center, everyone, they have their own mind setup. They will come and tell me that, sir, this drug cannot be moved if I'm keeping even as a minimal stock. But we enforce them, it has to be kept so that I can satisfy the patient. I can dispense all the possible medicine to the patient. Then we started educating, we started doing the very different audit. We have frequent audit has been done in all the units. And we used to do the surprise audits also. The placing a new inventory pattern, and education, and by training everyone, we could able to attain the Six Sigma levels, and number of errors has been minimized from 300 to 100, 1000 to 400, and 600 to 300, and 200 to 158. And this is all our tangible outcomes. So when you make your inventory process in very stable way, you could prevent the indirect loss when it's coming back to the return. Because when you place the direct orders, you may get a lot of discounts and all the things. When you return back to the medicine to the supplier, it all get cut. So you have indirect loss for that. So that has been minimized from 0.7% to 0.2%. Then total investment, the overall stock value, whatever we are having in a pharmacy, had been reduced to 7.1%. So we have satisfied the patients. We maintain the proper stock level, good experiments in documentation, and everything has been improved. That certain few intangible outcome, which means it's all overall the responsibility to take, that cannot be measured. Thank you.
I'm sorry, the time is up.
Yes, thank you, ma'am.
So again, Brito, wonderful presentation, good concept, basic concept, going back to basics, right? And trying to, thought it's wonderfully done also. And there are two questions, right? So
Yes, ma'am.
I saw the passion, like how you drove this project, and so that's passion is been seen in your
Thanks
presentation.
a lot,
And I can see that.
Thank you.
And I'm sure that benefits the organization.
Thank you.
So there is you mentioned about there is a pharmacy and there are sub-stores, right? I believe that there are sub-stores. So what is the inventory? So what's the formulary? How many drugs do you store? Is been listed in your formulary?
The sub-stores is meaning like different retail pharmacies, ma'am. We have the main store where we used to have the only procurement of the things. So we have different sub-stores. We have block A and block B. We have OTs. So different from the whole store, we cannot supply to all where. So what do we do is we have different sub-stores where to deal with the OP patient, to deal with the IP patients. So the inventory level of each pharmacist will be different. Where in OP pharmacy, I cannot stock all the IV fluids. I cannot stock all the antibiotics. Where the patients may not come and get for the injections in an OP pharmacy. But the patients who wanted to put on IV antibiotics, I need to keep certain stock. In case of an IP pharmacy, the inventory pattern is completely different, where I have a lot of patients will come for IV fluids, will come for antibiotic, will come for. So the inventory level of both the pharmacies will be different. So the sub-store, it intended that the retail pharmacies where it has a close contact to the patients than the main store.
Okay, so why I'm asking you about is that when we set up some processes, we want to simplify, the implementation, and there is no error risk. So when there is so much of variability with respect to different stores, so I'm sure you must look into taking it at to a next level, wherein you want to standardize at a certain level and then make it at a different level.
Yes, you are exactly right, ma'am. That we can easily calculate from the sales of the particular pharmacy. When you calculate the last 6 months sale, we could get to know what the average movement of the drug is. So based on that, we can set the reorder level. It could not be the same for all the pharmacies, because one particular pharmacy, the drug will move fast, and the one particular pharmacy, it may not. So the reorder level for the individual pharmacies has been defined properly, and we looked into the intending pattern also. So how the intent to be placed, how the rack stock to be maintained. So we need to look on all the patterns so that we could able to satisfy the patient needs without any delay. When you are being as my patients, I could supply all the medicine whatever you need to me. So it should not be like that a drug is not available in a particular pharmacy. What they will commonly do is they will refer to some other pharmacy where it's available. The patient may not feel comfortable, and
Okay. And how did you validate this data? So you were at what sigma level, when you started?
which how we evaluate that.
Yeah. What
So
was the level of sigma level when you started this, and how much?
it is like we started with 3.8 for purchasing unit. We end up with 4.2. Still, we are working on that, ma'am.
Okay.
So, but the total number of error has been minimized drastically from 300 plus to 100 plus. But still, we have 100 errors, and we are closely looking on it. And hopefully, if the project is continuously we are doing it. Like we could not conclude it. So, what are the data which we have spread it into half, and we are presenting it.
Thank you. Thank you, Preeti.
Thank you.
Congratulations.
Thank you. Thank you so much, ma'am.
As Shweta ma'am was mentioning, the spirit of you was commendable.
Thanks a lot,
And we could feel that you are aiming for the customer satisfaction.
Yes,
You want to
definitely.
make your patient 100% happy with their requirement, like whatever is being ordered by the physician or the surgeon, it's being made available by you in different pharmacy outlets of yours, be it inpatient or OP. I just want to know, how long did the process take to get compliance from, many people are involved, like a pharmacist or clinical pharmacist, or the doctors or the nurses.
And that's what the big challenge in our project, ma'am, because when the senior nurses, when it comes to the nursing, but the senior nurses a little bit good, to maintain the stock level. Even I could, whenever we used to go for an audit, we could see there are a lot of non-compliances in the maintaining the stocks. Then we are expecting little more than that. See, the management decide or the clinical team decide that certain drugs has to be kept it in the ward, but it remains unused. If I am keeping some cardiology medicines in the general ward of trauma patient, it is not being used, but the same drug can be transferred to the ICU for the replacement.
So that requires a consensus between clinicians across your hospital. How was it possible to make this happen?
It is mainly possible only because of the multidisciplinary team discussion. So what and all the things which I am auditing the nursing team, it is my responsibility to talk to my NS that this and all the differences which I have faced from the nursing team. Then her responsibility is to meet all the senior level nursing staff to maintain what the problem which we have defected. Whenever I am going to report to my NS, I will give her the report like this particular ward has the most deficiency. So in spite of concentrating on the whole, we will target the particular place where we are having lot of deficiency, then we will work closer. So when we are bringing down the error, so when we are targeting and working towards in the particular place, the total error has been bring down drastically.
Do you have a clinical pharmacist or a pharmacist in
Yes.
every department?
We have a clinical pharmacy, then we have a clinical pharmacy trainees. So what do we use? I used to put the clinical pharmacy trainees in the regular agenda. So I have posted them in a different floors, and the main agenda is to follow the regular maintaining of the drug chart, regular auditing the pharmacy, like how they are maintaining the stock, how many intending drugs were missed, it's the pending intending drugs and all the things.
Okay, thank you.
One observation, I don't have any questions.
Yeah.
Nice presentation, passion there,
Thanks a lot, sir.
but you need to slow down your talk.
Definitely,
You are
sir.
swallowing words, which is not a good way of presenting.
Sure, sir.
Lovely
Thank you.
presentation.
Sure, sir. Thank you. Thank you. Thanks a lot.